Okay, so welcome back. We had a spectacular morning. Professor Mir, I have to say that the talk was inspiring. It was just remarkable. I've gotten a lot of very positive feedback on the talk. It was just amazing. I hope everyone has had a nice bit of relaxation and interaction over lunch and over the e-posters. So we've got a couple of symposia then this afternoon. The first will be a symposium on global surgery and social change. And we've designed this symposium to complement the outstanding Gordon Murray lecture that we heard before. So just a few slides by way of introduction, and I'll briefly introduce all of the speakers. And I just want to again also thank Anna Dare for a lot of really good interaction in terms of putting together this symposium. So I think we heard quite eloquently from Professor Miera that global surgery is an essential component of global health, and this is just emphasized, I think, really in this article, which I think has, and I just kind of put the abstract up here. Global surgery is an essential component of global health. Global surgery is the study and practice of improving access to timely, quality, and affordable surgical care, and emphasizes horizontal health systems. And this is actually an interesting concept in terms of the idea of creating a horizontal system that's sustainable and not just always looking for the quick wins. And that actually is quite interesting as well, because there's sometimes a temptation to only go for the quick wins, which is not necessarily wrong, but in the end, we also need to create sustainable systems. And so the article, on the right, I made reference to, and the article on the left is first authored by our chair of global surgery, Anna Dare, and really kind of talking about this concept of global surgery kind of from a different lens, and really the idea around creating equitable systems of care. And I really like the concepts, John, that you were talking about, that Paul Farmer talked about in terms of, that kind of looking at things from the individual, basis. And so, the commitment to improve access, quality outcomes for all who need surgical care, no matter who you are or where in the world you live. And while we think that the issues of equitable care maybe are, in middle income countries, as I think all of you are aware, and as we'll hear this afternoon, we have issues in our own country as well. And so I think this also applies to the equitable delivery of health care to, individuals from remote communities and, other communities where there are some challenges. So, we heard a, very eloquent lecture on the whole, the output of the Lancet Commission, which I think was really, a landmark effort. And I have to say it was really visionary as well of the Lancet to put this together. I think it was really quite, impressive, and it was quite remarkable to bring this collaboration over, over 100 countries. I can only just imagine how complex those discussions, might have been over the course of a number of years. And I actually would welcome a revisit of this Lancet Commission. I don't know if that's being planned or not, but it would seem to me to be quite timely to consider that. And we heard about the gaps, but I think some of these numbers are quite remarkable. So that number on the left, 5 billion people, like that's staggering. It's hard to even imagine, that number in terms of the gaps in care, and the fact that, the lack of access to surgery is arguably one of the most important, if not maybe the most important, gap in terms of the equitable delivery of care around the world. And clearly surgery is an indivisible, indispensable part of healthcare. I think that has become quite clear. And we need to drive change in global health policy and in systems. So this is also reflected in our emerging global surgery program at the University of Toronto, and part of the timeliness of this year's Gallie Day is to really to highlight the tremendous work that has been going on, for many years in global surgery, and I think it's really becoming, galvanized now. And there's over 30 faculty and many trainees that are engaged, and there's efforts at the local level, at the national level, and at the international level that we're going to hear about, I think, in our symposium today. And I want to thank Anna Dare for providing some of these slides to me. So this is her slide here, just highlighting kind of the 6 pillars that are critical to the University of Toronto Global Surgery program. So these include clinical partnerships, education and training, health systems and policy, research, evaluation and quality improvement, engagement and advocacy, and of course special events like today. So that's important. Okay, so I'm just going to briefly introduce all of the speakers. I thought maybe I would do this now, and I'm not going to read everything that's up there. You can have a look at this, but we have Dr. Anna Dare, who holds a chair in global surgery at the University of Toronto, and she has an appointment in IHPME as well as at St. Michael's, and is involved in cancer care in her clinical practice. And Rajiv Singhal, and Rajiv, I enjoyed learning a bit more about your excellent work at dinner last evening. And Rajiv is the Surgeon-in-Chief and a Surgery Program Medical Director at the Michael Garron Hospital. He's a urologist and has been very actively engaged in the division, in the provision of advanced urological care in low and middle income countries. And then we have 2 speakers who are going to jointly talk about some of the issues I alluded to, which is some of the issues around equitable delivery of healthcare in our own country. And Dr. Jeff Fialkov is head of plastic and reconstructive surgery at Sunnybrook, and has been very active in terms of the provision of plastic surgical care in northern communities. And the co-presenter will be this remarkable young woman, Dr. Sayana Multaji, who is a senior resident in plastic reconstructive surgery, and she's been quite actively engaged with Dr. Fialkov in this program. And the final speaker is a relatively new recruit, Dr. Michael Achua, who did a lot of his seminal training in the Philippines before coming to North America, doing a fellowship training at SickKids, and also doing some advanced training in global health at Johns Hopkins. And Michael will be talking to us a bit about the use of augmented reality technologies for the education of individuals to enhance capacity in low and middle income countries. So without further ado, I will call on Dr. Anna Dare to deliver her lecture on Who Counts? How Collaborative Research Networks are Changing Our Understanding of Global Surgical Access, Quality, and Outcomes.
Great, thank you. So John has already highlighted today both this quote from Paul Farmer, that the idea that some lives matter less is the root of all that is wrong in the world, and his stellar keynote this morning. I'm going to similarly use this as a launching pad, but to reflect on what it means to do research. So most of you are here today because you're motivated to use science and research to solve difficult problems in surgery and to improve the lives of our patients. I am too. And while few of the most pressing problems in global surgery can be solved by research alone, the absence of globally relevant data on surgical need has been one of the primary drivers of its neglect within national and global health systems. I think perhaps most importantly, research and science shape our understanding of global health and our collective responses to health challenges. Who and what we choose to study can contribute, often inadvertently, to the unequal value different lives are afforded around the world. So this question, who counts, is really at the heart of the work that I do and that I'm going to share today. For all our scientific and technological progress, we still actually know very little about the health experiences and outcomes of the majority of the world's population. Each year, millions of people die in deaths that are not captured by vital registration systems and for which no information or cause is documented. Only around a third of all countries globally can currently report high-quality cancer incidence data. And the vast majority of all of our surgical research occurs exclusively in and for the global north. And really it's this absence of reliable data that renders people unseen, uncountable, and hence uncounted. It leaves countries unable to plan for the health needs of their populations. This is not just a problem in poorer countries. In Canada, a lack of disaggregation in our data sets disproportionately impacts marginalised communities. But I want to focus not just on what's missing from our global understanding of surgical disease, but also what's possible. To demonstrate that doing large-scale rigorous research that informs policy and practice is achievable in all resource settings. And also, I guess, to challenge you to consider who goes uncounted in your own research fields. So to do this, I'm going to use 3 different examples of global collaborative efforts we're involved with, spanning population, clinical, and molecular research. So let's start with a population-based study that allows us to estimate the number of deaths that occur each year in India because people cannot access emergency surgical care. India now has the largest population of any country in the world. It overtook China last year at 1.42 billion people. But most deaths in India still occur at home in the absence of any medical attention and without a known or registered cause of death. Without this information, it's really difficult to know how many people die each year because they cannot access surgical care, or even what the most common causes of surgical disease are. So to overcome this problem, the Centre for Global Health Research at St Michael's Hospital, which is led by the epidemiologist Prabhat Jha, has partnered with the Indian government for a number of years now to run a nationally representative population-based mortality survey, the Million Death Study, that uses a method for determining causes of death called verbal autopsy. We've had several of our Department of Surgery residents who have done research through this study. To collect information on the causes of death, trained field workers visit a representative sample of over 1 million homes across India every 6 months. If there's been a death in the house, they complete a verbal autopsy with the next of kin. This is really a 2-page document, not unlike the type of medical history that we take in clinic, comprising structured questions and free text narrative. 2 trained doctors then assign a cause of death on the basis of each autopsy report. Using this Million Death Study, we've been able to understand for the first time how many people in India die each year from acute abdominal conditions, such as appendicitis, bowel obstruction, intestinal perforation, and then to relate this to geographic access to emergency surgical care. So most acute abdominal deaths in India occur at home, in the absence of medical attention, in rural areas and amongst those with low educational attainment. Because the Million Death Study uses nationally representative sampling strategies, we're then able to estimate that each year in India around 71,000 people die just from acute abdominal conditions alone. There's wide variation, as you can see here, at a subnational level as to who's at risk of dying. And using spatial clustering, we can see that the age standardised death rate between hotspots, or areas with high mortality, and cold spots in the blue, the areas with low mortality, varies by almost 10-fold. So even within a single country, you can have significant variation in the risk of dying. We next wanted to understand whether geographic access to a government district hospital really reduces the risk of dying from acute abdomen. That's an important question for policymakers. And the short answer is it doesn't, it doesn't. It depends what you count. Only 39% of India's district hospitals have the resourcing to deliver 24/7 emergency surgical care, and many have no or limited surgical services at all. When we look at how this relates to mortality, the high mortality clusters were significantly further, seen here on the red, from emergency surgical care that could be provided within a district hospital, whereas there was no difference in mortality risk when we just looked at distance to any building, any hospital. The odds of dying increased threefold when you live more than 50 kilometres from a hospital capable of providing full emergency surgical care, and 16-fold when you live more than 100 kilometres away. This has pretty important population level and policy implications, because when you look at this at a population level, if we think about how many lives could be saved if patients live within 50 kilometres of a well-resourced hospital, we think it would be around 50,000 deaths from acute abdominal conditions alone each year in India. And I think these results really have emphasised to policymakers in the country that geographic access should not be measured simply as proximity to any hospital, but must focus on the capacity of the hospital to deliver emergency surgical care. So we don't just need more buildings, we need to focus on greater resourcing within the existing infrastructure to save the most lives. And I think when we reflect on our own experiences, that's a lesson that holds true in all corners of the world. So the second major global research effort I'm going to share today, and I know there are a number of people in the room who've been involved with this as well, focuses on collecting hospital-level clinical data in countries around the world to really try and understand what drives variation in access, quality, and outcomes after surgery. So Global Surge is a collaborative of over 5,000 surgeon investigators that run cohort studies and randomised control trials in more than 90 countries around the world. It actually started around 10 years ago as well as a bare bones trainee-led collaborative, and now receives continuous NIHR funding to the tune of millions of pounds, delivers high-impact papers, global policy guidance, and has a steady stream of PhD and postdoctoral students from around the world. The collaborative has really been successful, I think, for several reasons. It uses a democratic model of research prioritisation, in which every one of those investigators can vote on which research questions are most important. It uses pragmatic bedside data collection and endpoints, so studies run as part of the clinical flow rather than outside of it, and a PubMed citable group authorship model. That means all contributors can be cited as authors. I think perhaps most importantly, though, they've focused on building surgical research capacity among trainees and outside of high-income countries to ensure long-term sustainability. We've talked a little bit about the role of technology, and I think much of this work has really been made possible by embracing rather than running away from the use of newer technologies, including in the poorest countries. So this has really included the availability of low-cost tablets to facilitate hybrid data collection at the point of care, online data management repositories such as REDCap, and free open source statistical software such as R that allows any investigator anywhere to analyse the data they're collecting. So prior to this collaborative, there was really no understanding of global access and outcomes after cancer surgery. Anecdotally, there seemed to be higher rates of post-operative deaths, and that was often attributed to either poor surgical technique or more advanced stages of disease presentation in low and middle-income countries. So this prospective cohort study compared post-operative outcomes in patients undergoing breast, colorectal, and gastric cancer surgery in countries worldwide, including Canada, and focused on the effect of disease stage and complications on post-op mortality. In total, almost 16,000 patients from 430 hospitals in 82 countries were enrolled in the study. They came from all geographic regions across the world, as you can see here on the map, and from countries at all stages of economic development. The study confirmed that most patients undergoing cancer surgery in low and middle-income countries have advanced stage disease. You can see that here as the crossing of stage lines as you move from high-income countries on the left of each graph to low-income countries on the right. This is really the first time we've been able to show in a single prospective study just how different cancer presentation looks around the world. I think probably the next interesting finding, and you don't need to look at the details on this graph, but rather just the shape of the curves, is that despite there being vast differences in what resources surgeons have available to them in lower income countries, there was actually no major difference in surgical complication rates across country income groups. The rate of anastomotic leak after colorectal surgery, for example, was actually remarkably consistent. But when we looked at the risk of dying after a major complication, especially after colorectal or gastric cancer surgery, there was a much higher rate of death in patients in low and middle income countries. Now, some of this is owing to patient and disease factors, but actually when we looked at it on mediation analysis, much of it was due to perioperative resourcing. I think in Canada we'd typically refer to this as failure to rescue, but really in these settings it's about the capacity to rescue. In hospitals without dedicated PACUs, ICUs, or where there's imaging available, most in the study of which were in low and middle income countries, the chance of dying from a major complication was significantly higher. And this really drove the observed differences in 30-day mortality that we see between the high income countries and the lower income countries. So this study was published in The Lancet, but the real work began after publication, convincing countries and policymakers that rather than investing in expensive cancer drugs in low and middle income countries, the first investment needed to be in getting patients out of the hospital alive after their cancer surgery. And that again, this meant focusing on improving the care and infrastructure within existing facilities. So the final collaborative research effort I want to share tackles the challenge of understanding cancer biology and collecting and using molecular data outside of high-income countries. This work is from our African Research Group in Oncology, which is a surgeon-initiated research collaborative that actually started as an academic partnership between Memorial Sloan Kettering in the USA and Obafemi Awolowo University in Nigeria. Over the past 10 years, it's grown to involve 28 member hospitals across Nigeria and 7 member institutions in North America, including the University of Toronto. Argo's focus is on developing clinical cancer research and linked biobanks in Nigeria, as well as training the next generation of global surgeons and researchers. I spent a year as their fellow in 2020, and you can see here on the slide that one of our own general surgery residents, Betty Ibrahu, is currently working as a research fellow in Nigeria with the group. So one of the reasons Argo focuses on tissue banking is that most of the world's fundamental cancer research is currently undertaken in high-income countries and amongst predominantly white populations. But as you can see here, when we look at the global population, this in no way represents racial, ethnic, or ancestral distributions around the world. That's important as we realise that different molecular pathways lead to cancer in different populations. So a key question for this group has really been whether there are differences in colorectal cancer biology in Nigeria. This work stems from an observation that the 2 founding PIs, Peter Kingham from the US and Isaac Alatishe from Nigeria, made when they were both surgical oncology fellows together, that the clinical presentation of colorectal cancer seemed to be quite different in their respective countries. After founding Argo, they turned their observations into the group's first clinical series, which confirmed that left-sided colorectal cancers were far more common in Nigeria compared to the US, and the site of first metastases was also very different. In North America, most patients will present first with isolated liver metastases, but in Nigeria, there was a much higher rate of isolated peritoneal metastases. So to better understand this finding, we've used the tissue bank to identify the molecular pathways that underpin the development of colorectal cancer. You might remember, even if you're not a general surgeon or surgical oncologist, that the classic described pathway to colorectal cancer is the adenoma or polyp to carcinoma sequence, which occurs over a 10-year period. This is really the fundamental basis for early detection and screening in most of the world. Well, it turns out that that's the classic pathway if you're from a European ancestry population. But there's a significantly different distribution of colorectal cancer pathogenesis in other parts of the world. When we look at patients with West African ancestry, and particularly those still living in Nigeria, we see quite different molecular pathways of colorectal cancer development. You don't need to look in any detail here, except to understand that compared to both Memorial Sloan Kettering and US populations, and populations that are reflected in our supposedly global cancer genome atlas, we see much higher rates of microsatellite instability within colorectal cancer in Nigeria, without the same common BRAF mutation we might see in high-income countries. This finding is actually immediately relevant to access to care at the moment because most rectal cancer is treated with a combination of chemotherapy and radiation plus surgery. In Nigeria, patients pay out of pocket for cancer care. Many travel hundreds of kilometres to get to a radiation machine. There are only a few in the country. But if your cancer formed through the microsatellite unstable pathway, as 25% of Nigerian colorectal cancer patients did in our study, you actually get little benefit from the standard chemo. And you may not even need the radiation or the chemotherapy at all if you have access to immunotherapy. In fact, in a recent study from the United States, 10% of patients with the same type of colorectal cancer mutation had a complete response to immunotherapy and could avoid chemo, radiation, and surgery altogether. However, less than 10% of patients in the United States actually have this type of colorectal cancer. And so perhaps not unlike the story of antiretroviral medication for HIV, the greatest clinical benefits from immunotherapy in colorectal cancer may well actually be for patients living outside of the global north. Unfortunately, translation of paradigm-shifting treatments from high-income to low-income countries has traditionally taken decades, if it's occurred at all. There are a lot of reasons for this and many barriers to undertaking clinical trials in low-resource settings, but it's certainly not impossible. So to prove this point, Argo opened the first phase 2 clinical trial of PD-1 blockade immunotherapy in Nigeria this year, less than 2 years after the publication of a paradigm-shifting trial in the New England Journal of Medicine. Of course, the next and highly relevant question is, well, what about access to such an expensive patented immunotherapy drug after the trial finishes? And so simultaneously, we've been looking at how to increase access to high-value cancer medicines outside of high-income markets, using many of the same patent pooling and tiered pricing mechanisms that have allowed HIV and TB medications to be affordable for all countries. So I hope I've given you a 15-minute taste of what is possible in global surgical research when we work together in global partnership. That rigorous surgical research can and should be done in all settings. And that an understanding of global surgical need drawn only from high-income countries, it tells an incomplete story and cannot be assumed to translate across diverse populations. So finally, I want to return to my first question of who counts and challenge you all to think about how, in your own work, as surgeons and as scientists, you can commit to making everyone count.
Thank you, Anna, for that excellent talk. So I think what we'll do is we'll hold questions until the panel discussion. So next, I'd like to call on Dr. Rajiv Singhal, who will talk to us about building urological capacity in Malawi.
Thank you, Michael. That's the pointer, or?
Yes.
Okay.
No,
That's the pointer. Very good, Rebecca. Thank you, everyone, for inviting me to, I think, what's a very important talk for surgeons to try and grapple and have an impact on in an increasingly complicated world. So I just thought I'd just sort of reflect on my own journey in global surgery and some insight that's come from that and where we might be able to go from there. And so much of like what you've seen today already, and to borrow from some themes that Dr. O'Meara have already talked about, the Lancet Commission, I think, weighs quite heavily in our thinking around global surgery. And you've seen the slide, you've seen the quote. It has been neglected, though the work is enormous, and certainly the access is very skewed towards the industrialized world in terms of who can actually access that surgical care. And there are increasing missions. As a urologist, I think that's something that we've come to fairly late. But I would submit that these are all new. We're in interesting times, and we're not going to right-size the world overnight, and we have made an impact if we look at the course of human history, and as people have been lifted from extreme poverty over the course of the last many decades. And so there's fundamental things that need to start and be in place as we then look to see what we can build on. And so if we think about that, and then how do we prioritize global health? Our understanding of modern global health, and my understanding, is actually fairly new. It's less than 50 years old. And so if we start with the World Health Organization declaration in Kazakhstan that really spoke at that time to this concept that basic primary care and the concept of healthcare as a primary human right. It's not that old. I was a teenager at the time, and so these are not long concepts. And so I would submit we needed to get a few things in order before we started to think about surgery. And so from there, the next major thing was the Millennial Development Goals in 2000, and rightfully so, we needed to tackle the issues of the time around communicable diseases, safe water, all these kinds of things. And so there's been an evolution, I would submit, that has led us to this point where I think surgery has an opportunity to shine. And again, just to borrow again from the Lancet Commission, it matters. There's lots of people that are dying, and this is directly off of the website. And if you can't do a deep dive through the paper, there's actually a great website that goes through a lot of these themes. And if you actually look at HIV and malaria and tuberculosis combined, more people die from surgery than all of those combined. So this is a big problem around the world, and something that I think we need to be mindful of. And so it was in that context that I first made a trip to Malawi. There's been a lot said about serendipity, and I would say the timing for me was very serendipitous. I was at a stage in my life, my kids were at a point where they're all off to university. I had about 15, 20 years in practice. And the Lancet Commission had just been published a year before. So again, a very interesting time, and I'm not sure if I'd even gone 5 years earlier, I really would have had any concept of what I would have been able to do, or what I might be able to do. And so just a little bit about Malawi. It's a landlocked country, like most of the eastern part of the continent. There's a lot of English and British influence at the time of colonialization. I grew up as a kid, I used to see these stamps from Nyasaland, so that was Malawi, it was Nyasaland, and surrounded pretty much a landlocked country with a lot of people, and it's a wonderful place. Its nickname is the warm heart of Africa, and it really is special. And so my first thoughts really when I went were just, I wasn't sure what to expect. You know, I'm a surgeon that works in Toronto. I have access pretty much to everything I need. And so a lot of it was just trying to have that, take in the experiences. So I would submit this was actually a relatively well-equipped operating room. And so it takes a little while for your senses, for somebody who's new to be overcome, or to adjust to these sorts of things. And there's a lot of basic challenges. So my very first day there, or I guess the first full day, there were a couple of minor things we were going to bring down to the, to maybe do, and I was going to help the clinical officers. This was Macmillan, who was one of our clinical officer anesthetists at that day. And I came down, and I'm not sure how well that reads, but they put the blood pressure cuff on, somebody who's been waiting presumably for days, and it was, he was in a hypertensive crisis. And so, you realize how big the basic problem, just getting back to, even if you get people to an institution, can you actually deliver something safely? And so nobody had really bothered to check this poor man in terms of his blood pressure until he came at that point in time. Concept of consent, we spend a lot of time documenting what we do here in our own institutions, and so this is in fact the surgical consent at Zomba Central Hospital. I suspect it would not pass our guidelines here. And so there's a lot of faith and trust, right, put in the hands of people who just want to be treated with dignity and make sure that they're being treated fairly. So we have to respect that, because that is the environment we're in. But what I found was people who were wonderful, who were very interested in wanting to learn. That is Daniel, who was one of the clinical officers, a surgical clinical officer, and Mary Issa, who was in the OR. And then every morning the team would gather at about 7 o'clock and sort of describe what came in overnight. And so it was an opportunity to start to have some dialogue. And so that was the start. And then so just a little bit about urology in sub-Saharan Africa. There's not a lot of data, just to speak to what Anna just spoke to. There's certainly not a lot of urologists. So generally speaking, the numbers are very small. There were no urologists in Malawi in 2016. And so just keep that number in mind as I get towards the end. And in contrast to that, in 2019, there were 730 urologists here in Canada. And obviously there's very little equipment. And so really what you have is one general surgeon who primarily will oversee everything, but he or she has their hands full dealing with traumas and fractures and complicated C-sections. And then you have a clinical officer who I met. There was Daniel, and then Duncan, who really had an interest in urology. And there was very little in the way of scopes and other equipment to look for. And so urologic disease is very neglected. It presents late. It's BPH, it's prostate cancer. How we usually manage it is either with a catheter, and then people go off to their villages, and then they're neglected, right? Because there's so many other things to do in that operating room. And so people are often lost to follow-up for many, many years in terms of managing things like chronic catheters. And then access to definitive therapy, the financial constraints are just a disaster for people. I mean, just to contemplate, am I really gonna make that trek for 8 hours or 10 hours? Can I live with my catheter? These are all things that are very, very important. And so I left that first trip just trying to think about, well, what would be some early goals that I could maybe kind of get my head around. And certainly there's this concept of being able to provide some basic equipment. That's certainly hard to maintain in the longer term. I toyed with the idea maybe there's enough urologists here in the city or around the GTA. Could we go for 1-2 weeks at a time, every 6 weeks, and there's 7 or 8 or 10 of us, and that becomes some kind of model of sustainability? Maybe you're going to one community. How much of a difference are you really making in that concept? Certainly the clinical officers, I think just training them to do some basic surgery is good. Just teaching them some basic urology. I mean, even around medical management and decision making, I think there was some value to that. But the key piece is the fourth piece, and that I really felt this was an important piece, is that we needed to identify a bright, motivated doctor in Malawi, a Malawian, a native Malawian who would be training and willing to go and train within CASEXA. And so I'll talk about CASEXA just in a minute. And so I kind of think about these three foundational pillars, and it's really all guided by the Lancet Commission in terms of how I think about this. But central to this is patient care, and then we have to teach, and we have to figure out a way to measure and then report that work and that data. Big issues there. And then I'll speak a little bit at the end about philanthropy, because I think philanthropy, fundraising, optimizing the funds that come in to try and support some of this work. So a little bit about CASEXA. It's basically the Royal College in that part, the College of Surgeons of Eastern, Central, and Southern Africa. It has evolved over the last 25 years to be able to really set the standard for surgical training, really across all disciplines now, general surgery, orthopedics, pediatrics, certainly urology, and that has provided, I think, the backbone for surgical training in sub-Saharan Africa, and is really something that I've taken to focus on. Retention is a big part of it, and you know, my dad came in the 60s to train as a surgeon, as did many in that generation from India at the time. But if you can have people train safely and get those skills, ideally close to home, I think there's a higher chance that those communities would be served. So retention, certainly the data, the CASEXA data has really supported the idea that if you're a Malawian and you train in CASEXA, you'll stay in Malawi or you'll stay nearby. So a very important concept around retention. It's had a major impact, so there is a CASEXA training log for trainees in terms of the case logs that they do in all of the different programs around the continent, and they just passed earlier this year 500,000 cases. As you can see, there's a variety of different procedures and specialties. So there's real work being done in a lot of places around Africa. It's very cost effective. So this is actually just a screenshot from one of our memorandum of understandings that Nancy Kondo and I put together with a couple of our trainees. So this is the total cost to train a resident in CASEXA for 5 years. And as you can see, the 5-year total for one person is $40,000 US. And so we've trained 2 in this particular memorandum. So for $80,000, $16,000 US a year you can have a surgeon in 5 years. And that's pretty much true across any specialty. Very cost effective. And so, and I went back the next year, that was my first job, was trying to identify who might do that. So I will introduce you to Dr. Wanengwa Chisenga, who somewhere along the line became my fourth child. I had a number of conversations and pep talks that we would do over the course of several years. But he actually was our first University of Toronto supported urologist from Kasexha. And so by 2020, when Wanengwa graduated, he came back to Zamba, this place that I went to back in 2016. And by that time, Charles had already come back as well. And we had two. So by 2020, we had two. Relationships are the backbone of anything we do overseas. I think we have a lot of assumptions about what we can do. I don't know, John, if you've met Dr. Borgstein. So he's the Secretary General of Kasexha. He has given me all of my guidance around how to approach surgical training in this part of the world. He's on the executive of Kasexha. He's a pediatric general surgeon, has built this great place in Blantyre, a lot of it with Madonna's money, and has provided a lot of my focus. So Eric has been a big part of it. I want you to meet two of my fellows who really have become, I might be sitting up here today, but both Olivier and Tristan, who've been my endourology fellows over the last 5-6 years, have really picked up the mantle, have gone a couple of times with me, have gone on their own, ostensibly came to learn how to be urologists here in Canada, but have really embraced and helped me drive this sort of vision. Dr. Mothus, Dr. Henning Mothus actually is the surgeon who was, when his family was young, was in Zamba about 20 years ago. He spent 3 years stationed as the main general surgeon at Zamba Central Hospital. He's the fellow third from the right on the left picture, and he brought the German team. So he's fallen in love with the country. He comes once a year and has provided a lot of support to build out what he calls the Zamba Urology Project now. He himself is a general surgeon. This is some of the teams. Charles, that's his sister, who's an anesthetist in Zamba, and Enoch Lutsu is Henning's now current general surgery lead at Zamba, the fellow in the middle with the picture of 5 of us, and that's Olivier and Wanengwa on the right side of the screen. And so it was with all of that. Now, we had a pandemic, so there was a little bit of a delay getting back, and so we finally made it back about a year ago. Everything we bring back equipment-wise is in partnership with industry. I think that's the best way to leverage industry. It's not to use fundraising dollars or any of that precious resource. And so we came back, and in many ways, while it seemed to be the same, a lot had changed. And so that picture on the right, that's Olivier working alongside Wanengwa, doing an open simple prostatectomy. The OR looks a little bit better equipped. The little mention of this little bit of technology, it's a little startup company. I sort of brought it with me just to show it off, this little orb. It's a light source. So instead of towers, that orb communicates with that little disc that's on the table, and then you can basically project with the projector whatever you're doing on the screen to the white OR wall. Very cheap way to potentially leverage some endoscopic kind of work in the developing world. Not to be forgotten, the clinical officer. So that's Duncan to the left with me and Wanengwa just talking and kind of going over the case. And so, it kind of went from doing a lot of stuff to now working alongside our partners on the ground. And so, it's been very gratifying to see. So we had 2 by 2020, a third just finished, a female urologist. We have 3 that are University of Toronto supported urology trainees, and I'm going to show them to you in a second, who are in the system, who will finish in 2025. So the mapped out plan for Malawi in terms of urology workforce is 9 urologists by the end of 2027. And then we've gotten to start working now on some anesthesia support, because the 2, of course, have to go hand in hand. So that's the current trainee group, who are the PGY4s in the audience. So they're basically PGY4s, the 3 of them on the right side of the screen. And then the anesthetist, the anesthesia resident, Dr. Solomon, who's on the left with the picture of 4. all eager, all ready to contribute as time goes on. Hannah, I think, is in the room. I don't know where Hannah is. So Hannah is one of our PGY4s in the corner. So Dr. Thomas is a urology PGY4 here in Toronto. Much smarter than I am, very much focused on making this much more academic. I would submit that investing in global surgery as a University of Toronto program makes our own trainees better if they can go on elective rotations. You know, you get used to working a certain way, going into an environment where you're forced to make pragmatic decisions in the name of safety. That's very different. I think it just makes better doctors. And then that's sort of the final group. The little dynamo in the middle, that's Dr. Stella. She is the lead anesthesiologist in Blantyre. I'm starting to work with her quite actively now to try and build out the anesthesia support in the next 2 or 3 years. And so that's going to be a big thing. And so just to close it off, what can we do at the university? Why are we positioned to make a difference? So as we've seen today, we have many globally dedicated faculty. We are already leaders in surgical education and training. This particular forum that we have every year for the last 50 years is proof of that. And I think it's needed to sustain long-term programs. There's tremendous expertise across all of our specialties, and we can certainly leverage our reputation that we have here. And then also, I think we need to light a fire. You know, I mean, Asha, I met last night. That's the generation that's going to take the mantle and grow this and scale it. You know, our residents coming, so they need to see it from all of us, so that we can then let them take it from our failing hands. And so, in terms of next steps, I think we'll continue to scale up urology and surgical and anesthesia capacity. And I wouldn't mind exploring similar men's health initiatives, maybe in other parts of sub-Saharan Africa. And I think you can use this kind of training model across other surgical disciplines, whether it's orthopedics or whether it's general surgery. And then I think ultimately we transition from side-by-side training to mentoring through simulation, through VR, remote care, chat groups, whatever that might look like. And so I'll leave it basically just with a final piece. Fundraising is important. I was lucky. So Jim Rutka and Carol afterwards have been amazing supporters of global surgery. So we were able to set up a fund a number of years ago. It's been very gratifying to see the support. We've raised a little bit of money. And I just wanted to particularly thank Effie Orden, who's right back there in the middle, for all of the work that she does in the advancement office to grow the word, steward our potential donors, and really just make the rest of us look good. So thank you, Effie. And I'll leave it at that.
So the whole question for the end. Thank you. So the next presentation is actually going to be joint, and we have Dr. Jeff Fialkov and Dr. Sayena Multaji. And so Dr. Fialkov will talk to us about bringing ambulatory plastic surgery in Canada's far north, and Dr. Multaji will then complement that with her talk on the true north, quality improvement of plastic surgical care in the Northern Canadian territory of Nunavut. Thank you, Michael. Oh, I guess you're going to see 2 slides at a time. Thanks very much. This is a great honor to be here today. I wonder if they can switch that. It's a little distracting. Okay, thank you. It's a great honor to be here today, and I think I just, off the cuff, wanted to highlight that all the themes you've heard today in terms of global surgery are shockingly themes that you're going to recognize in our own backyard. And I think I just wanted to start with that, because I can't overemphasize the importance of recognizing the disparity that we have here in this country between the Indigenous population and the rest of us who are blessed with incredible health care. So I'm going to, by way of overview, just let you know about the challenge that is particular to northern communities, northern Indigenous remote communities, the burden and barriers that are posed by medical travel,
I'm going to tell you about the clinic that we established in Nunavut, and then I want to tell you about the impact that provision of local surgical care has provided or has had on the health and welfare of the communities in the north. But I'm not going to get into the data because I'm going to leave that to the incredible Sayana Multaji. I'm going to just tell you some patient stories to give you an idea of what we have going on in our backyard. So one of the biggest challenges is the remoteness of the communities that are in Canada's north. There are very small populations. There are no hospitals. There's very little infrastructure, and they're landlocked. They're land and water locked. So in order for somebody to get medical care in a specialty, particularly surgical care, they have to take multiple flights. It's an arduous journey, and they usually have to visit some southern center. And often those flights are impaired by inclement weather, which is very common in the far north. And this all adds to even longer wait times and more impediment in terms of access to health care. So medical travel is a huge socioeconomic burden, not just for the government and for the local territorial government, but also for the patients themselves in these communities. This is impoverished, these are impoverished communities. These are little dwellings that are across the health center from where we work. And in each one of those cubicles, you can find a family of 7 to 10 people, all interdependent, people that are caregivers, people that are hunters, fishers, breadwinners. And so if somebody needs to go for a 15-minute consultation to Winnipeg from Rankin Inlet, which is where this is, in Kivalliq region, that 15-minute consult will probably be a 2 to 3 day trip. And if that person is a caregiver of the elderly or the young, or a breadwinner, or it's hunting season or fishing season, and they have to bring back food for the family, that's a huge impact on that family. The government doesn't pay for everything. There is some copay, and most of these people are either seasonally employed or unemployed, and they don't have third-party insurance as a result of that. So of course the concept is a simple concept, and everyone who's a global surgeon knows that the idea is to bring the surgical services to the patients, to the communities. But of course the lack of infrastructure, the lack of staffing, the lack of, I think as Dr. Miara said, stuff and all the S's, all those things, that deficiency makes it very difficult to actually provide surgical care in these very remote regions. But plastic surgery is different. Plastic surgery is very transportable, and we can do an incredible amount with just local anesthetic. And the way I saw it was that this is actually a wedge in the disparity. Perhaps we can start with procedures that we can do under local anesthetic and then open up the door to increasing the services. And so that was our goal. Our goal was to provide high quality plastic and reconstructive surgical care to these local remote communities in order to reduce wait times, reduce travel costs, improve access, and alleviate the burden of medical travel. When we did a needs assessment with the help of the department, the Territorial Department of Medicine or Health, we found that the population that was most in need was in the region of Kivalliq, which is the central region of the territory of Nunavut. And the capital of that region, with a whopping population of 2,800, most of whom are transient, is Rankin Inlet. Why we chose this area was because at the time of our needs assessment, we found that there were about 100 patients waiting for plastic surgical consults, and the average wait time was 36 months, if you can imagine. So they really were in need of local care. We also found that they had a very impressive facility and resources that were made available for our use. It's not a hospital, but it's a health center. They used to be called nursing stations, no longer. But it has 6 inpatient beds, a resuscitation room, which we converted into an operating facility, an X-ray machine, an ultrasound machine, and most importantly, sterilization capacity. And the government of Nunavut was very, very happy to provide us with the instrumentation we needed and the equipment, knowing very well that we were going to reduce the costs of medical travel, and that would create some monies for us to use. The greatest resource, as all of you I'm sure know from your global surgery experience, are the people. And the people in the Cavalli Health Center are incredible. They don't know the meaning of the word no. Their primary goal is to just better the lives of their fellow community members, and they are really, truly incredible people. So what have we done to date? Since 2019, we've actually held 8 clinics. We've seen 585 patients. We've operated on 234. And about a third of those patients are hand problems. And this is in keeping with the lifestyle that the Inuit people live. They live a very harsh manual lifestyle. They use their hands for hunting, fishing, building equipment, repairing equipment, building tools. And so they have lots of carpal tunnel, lots of trigger finger, which are very, very easy conditions to treat under local anesthetic. So that has made a huge impact. Again, Sienna is going to talk to us about the data that we've collected in terms of our quality assurance studies and the impact that we've made. But I wanted to share a few stories which I think are going to drive home the point that there is such an incredible disparity in how the provision of local surgical services can really make an impact and really change things. So this little guy, I think he was about 7 years old when we saw him, 7 or 8. He was born with syndactyly, which some of you may know is fusion of his fingers, and he was treated in Winnipeg. Again, had to undergo medical travel to get his consultation, then a second trip for his treatment, and was lost to follow-up. And of course, this is the problem with medical travel. There is a disruption of continuity of care. It's very arduous, very difficult. As a consequence, he developed a postoperative infection which was unrecognized, and you can see the consequence there. He developed a horrible contracture of his finger. This is irreparable. He's been like this for years, and because of the contracture of his joints, he will not be able to ever use that finger and probably that hand again. So from the start, we realized that local care has the advantage of time that we can spend with the population. We decided we're going to stay there for 2 weeks at a time and do our complex surgeries in the first week, allowing us to follow up in the second week with patients to ensure that they haven't developed any acute complications and to treat them if they have. We've also developed an incredible relationship with the nurse practitioners in the various small communities. We have open relationship with them, and they are very, very eager to communicate with us about patients' follow-up and about their postoperative course. And this has been fantastic, and they know us at this point. We also have the ability to allow patients to stay overnight if we do a particularly large surgery or something that requires monitoring. And we quickly learned that we need to visit twice a year. Why? First of all, it allows us to have long-term follow-up, and we can see patients every 6 months if we need to. But most importantly, we have to be respectful of their lifestyle, and this is a little bit of cultural sensitivity. For these patients, hand problems are things that they live with. Deformities that we treat are things that they live with, and their priorities are sustenance, fishing, hunting. And if we hold a clinic during fishing or hunting season, they're not going to come to the clinic, they're not going to have surgery. And so twice a year allows us to book them in the future at a more convenient time. So the disparity, again, this is an example of the problem of timely access. This is a 30-year-old man who has ankylosing. Now, I think most of you who are parents or certainly plastic surgeons or oral surgeons know that ankylosing is a very simple thing to treat. It's tongue tie. And when you're an infant, you take a pair of scissors and snip it and you're done. The problem with remote communities is there's nobody to see this, there's nobody to diagnose it, and there's nobody to treat it. And in order to do so, again, medical travel is required. So this 30-year-old gentleman was born with ankylosing. He's trying to stick out his tongue in the picture to the left, and you can see the tip of his tongue doesn't move beyond his teeth. And this should have been picked up in his infancy, or at least in his childhood. We saw him, as I said, at the age of 30, and in 15 minutes we were able to do a small procedure to release his ankylosing, reconstruct his tongue, and as you can see on the right, give him full movement. But at that point he had developed speech impediment, he had difficulty with eating and chewing, and so this is the discrepancy and the disparity in access that we have in our own backyard. So by having a regular schedule of visits and a frequent schedule of visits, we're able to pick up these things and we're able to impact the access that the community members have. We're also able to expand services because of the skill and the dedication of people like the person on the right, Dr. Ramani, who's one of the family doctors. These people are incredible, as all of the healthcare workers are up there. She's able to provide conscious sedation, which has allowed us to expand our ability to provide service. And here you see we're doing a quick, easy ankylosing release on a baby, which we've done several times. For those of you who know about the history of the Indigenous people in this country, you know that there's an incredible lack of trust, and it's a justified lack of trust given the history of racism. This is a gentleman who developed bilateral blepharotosis. You can see his droopy eyelids. And he was unable to see very well because it blocked his peripheral vision. He was treated in Winnipeg several years before we arrived, and unfortunately he had a relapse, which does occur not infrequently with this operation. But no follow-up was arranged. Nobody bothered to see if he was doing well, and he just assumed that it didn't work, and this is the way he's gonna have to live for the rest of his life. So we saw him initially, and he refused to have a revision. We offered it to him, but he was not trusting of the fact that it would actually have any effect. But over the years, as we visited more frequently, and we saw him several times, and he learned that we were actually operating on some of his fellow community members, he decided to allow us to do one eye. And then when he saw that we had some relative success, the next year he came back for his other eye. So trust is something that has to be built, something that has to be earned, particularly in light of the history of this country. And this is something that the provision of local care frequently on a regular basis allows us to achieve. So here's a little girl that I just wanted to sort of summarize the flow of what we take for granted, the flow of continuity of care and access. This little girl has cryptotia. It's a buried ear in the scalp skin, as you can see on the left. Now, for this little girl from Rankin Inlet, she would have had to go down for a consultation, travel to Winnipeg, fly back, probably wait 2 years, maybe even longer, to have her surgery. And then probably, again, get lost to follow-up through no fault of anybody's. We saw her on the day for consultation. The same day we did the procedure that you can see there on the left, which are local flaps to release the ear and bring it out. We were able to see her the week after surgery, and then 6 months later in our follow-up clinic, we saw that she was doing well. And this continuity of care and access is something we take for granted here. I mean, that would be something that everybody would expect. But in our remote Indigenous communities, unfortunately, that is not the case. We do know we've had an impact on cost. To treat 100 patients from a small town or small village called Coral Harbor in Winnipeg, it would cost the government about $2.9 million to treat 100 patients with the same diagnosis. If we treat them in Rankin, we save on time and cost, and for the same number of 100 patients with the same diagnosis, it costs about $184,000. Taking into account the cost of providing room, board, and travel for surgeons, we save the government of Nunavut about $2.6 million per 100 patients that we see. It's astounding, but that's what medical travel, that's sapping the resources of the territory. We're also trying as best we can to impact some capacity building. This is more challenging because of the lack of the S's. But we are trying to educate as much as we can. And on the left, you see Paul Binhammer, who's the hand surgeon who accompanies us. He's giving an in-service on carpal tunnel to the staff of the health center. And there's Sienna, our superstar Sienna, teaching AJ how to suture. We started this program where the high school students can come and observe us in clinic. And this is a great story. AJ visited me last year at Sunnybrook in the operating room to see some big surgery. And she is inspired to become a surgeon. So she's doing healthcare at UBC this year, and I think she will achieve that goal. So in summary, I just want to mention once again that providing local care frees up resources. It lessens the socioeconomic burden for patients that really have an arduous life trying to achieve access and healthcare equity. And we hope, and I sort of alluded to this when I spoke to John at the break, we hope that somehow we can formalize this and create policy to allow the redirection of the funds that we're saving, a significant amount of money that we're saving the government, to be able to build capacity, build infrastructure, and ultimately incentivize more surgeons to follow in our footsteps. And so now I'm going to turn over to Sienna, who's going to tell you a little bit about our quality assurance work.
Okay, thank you for the opportunity to speak today on the local perspective on surgical care provision in Northern Canada. So to assess whether we were meeting the goals of the clinic, we conducted both a quantitative chart review and cost effectiveness analysis, as well as a qualitative study focused on gauging local perspectives. As part of the qualitative arm of the study, we interviewed 6 local healthcare providers and 10 patients. We then conducted thematic analysis on this data based in grounded theory. I'll be sharing the key themes that emerged. So a majority of our patients discussed the effect of our clinic on wait time. All felt that there was a shorter wait for local care. Patients described living with the condition that they had for as many as 10 years, 20 years prior to the institution of a local clinic. Our chart review, spanning 8 clinics between 2019 to 2023, found that the average wait time for treatment in our clinic is 4.6 months, as compared to an estimate of 9 to 16 months for an initial assessment at a Southern center. When discussing quality of care in the clinic, 86% of patients we spoke to were satisfied. Patients said they no longer felt so much pain and were really happy. One patient questioned if there were less instruments available locally, and if for that reason care down south might be better. 5 patients directly compared their experiences with local treatment and treatment in Winnipeg, and all of these patients felt the local care was either equivocal or superior. All patients described the previous norm of medical travel as a major socioeconomic burden. Obstacles of arranging childcare and being away from work were raised, and these issues are multiplied by a number of trips needed for investigation, consultation, surgery, and follow-up. One patient describes the stress of leaving work because he is the only IT specialist for 2 neighboring communities, reflecting the added pressure of a lean workforce in professions up north. He expressed relief that consultation and same-day procedure in our clinic took a few hours out of his day instead of a week of traveling. The one positive of medical travel identified was that it does allow an opportunity to shop for items unavailable up north while in Winnipeg. 5 patients and 3 providers commented on the advantage of social support with local care. As one patient said, "I have family here. If they send me down south and I don't have any escort and something happens to me, nobody's going to know. That is the scary part." Another patient expressed concern that this fear can actually deter patients from seeking care. Patients felt both more safe and more emotionally supported when they were able to have surgery in Nunavut with their friends and their family present. All participants that commented on healthcare communication found that this was a major issue in Northern healthcare, and also felt that a local care model can afford some improvement. Multiple patients described how challenging it can be to have information such as instructions or cancellations get lost in translation between Winnipeg and their health center. This can result in traveling south with all of the burdens that entails, just to find out that you needed an ultrasound before getting your consultation, or that the clinic has been rescheduled, which is a common experience. Continuity of care also emerged as a key theme. All patients who discussed this felt that they had improved continuity with local care. One patient explained that, "You guys remember me. That's really good, and it made me feel comfortable." Another explained that it matters to some people that they keep seeing the same doctor, referencing the benefit of building rapport with our team over a number of years. We have learned so much from listening to our patients and our peers in Rankin Inlet. Some of the challenges to delivering surgical care up north are obvious. Others, like the barrier or fear of traveling alone to a strange place, are informed by lived experience and are equally important to defining healthcare gaps and how we can rise to meet them. The strengths of local care that were identified by our patients drive us to make this clinic sustainable in Rankin, and also to consider how the same model may benefit other remote regions of Canada. Thank you for your time, and thank you to Dr. Fialkov for allowing me to be part of this journey.
Thank you. Very inspiring. So the final talk in this symposium on global surgery will be by Dr. Michael Chua, an initial report on collaborative global surgery education program utilizing a mixed method of in-person and augmented reality technology.
Hi, good afternoon. It's an honor for me to share my experience on the global surgery work and in front of more senior and experienced global surgeon in the room. So I am trying to present mine as a learner and share my experience as well as the limitation we encountered in doing this kind of mixed method of in-person and AR or augmented reality technology involved in the global surgery. As a disclosure, again, I'm a junior faculty, so I'll be presenting this presentation like I'm presenting a project so that hopefully the trainee will be more involved and have sense of relevance. So as an introduction, access to surgical care in the low to middle income countries is limited, as you probably heard in previous lectures. And global surgery, as in Lancet Commission, who Anna there co-authored, have highlighted that it intend to improve access to essential surgical care among LMIC. And traditionally, surgical medical humanitarian mission lack continuity of care, as you just heard earlier prior to my talk, and it's quite costly, and several logistic hindrances are considered. And with the augmented reality as a technology that enhance the real world environment combined with virtual reality. So the difference with the virtual reality and augmented reality is there's a real environment involved in the whole technology. That's the reason we're able to apply it in the intraoperative or at least in the clinical setting rather than just for a training purpose. And in the middle of a COVID-19 pandemic, AR have been actually gaining a lot of popularity, and there are many reviews and studies came out in the span of the pandemic. So in the Philippines, so where I had my medical training as well as my residency, you can see how we operate our patient. There's nothing we can talk about sterility in terms of doing our penile surgery in the area. And obviously, there's several limitations about reconstructive surgery, particularly in our space. You can see we would just clean our instrument right there and there with just soap and water and soak it with Cidex for a few minutes. The suture, sometimes we also wash and soak with Cidex and reuse it in another patient. And this is how we've been doing our procedure because of resource restrictions. And this is our team there, where we work with the St. Luke's Medical Center. This is our foundation that they'll go to the community at least once every 2-3 months, and we travel around to help our patient. And majority of our patient, if we think it's a difficult case, we'll bring them back to our hospital, schedule the procedure electively, and hopefully we're able to have a better outcome, particularly for the reconstructive one, and for pediatric cases as well. So I have worked with few undergrad students, and they did scoping review about application of AR in medical training, which showed quite impressive improvement in performance, knowledge, and their learning outcome. And another scoping review we did is application of the AR, particularly in the low to middle income countries, which showed success and promising potential. And that's the reason we applied the same concept in our own setting as well in the Philippines. So as a quick background, again, I'm personally from Philippines, and I'm fortunate enough to be landed here as one of the junior faculty. You can see the map of the Philippines. We are actually consist of several thousands of islands. And imagine how would be a patient travel from one island to another island, which may cost them as well as the time travel and all those limitation of doing surgery and seeking healthcare. And that's the reason we are coming up with this collaborative global surgery education program that we are aiming to work with 2 tertiary referral hospitals first right now, where the local surgeon will be eventually be the one to travel to the remote area or the different island to do the reconstructive surgery for our patient. So again, there are beautiful islands in the Philippines. However, if you look closely to our community, this is the reality, unfortunately. And it is well needed to have increased capacity for the surgical need, particularly in pediatric and reconstructive urological cases. So the project that I'm working with, which is under the Global Surgery Department of Surgery at U of T. So we reach out to Southeast Asia, particularly in the Philippines. We collaborated with St. Luke's Medical Center, which is a nonprofit hospital, and Philippine General Hospital. We just recently added this site as the biggest government hospital in the Philippines. And basically, we've been starting to do some didactic over the virtual session to increase the knowledge as well as case discussion before we select the appropriate case for the in-person as well as for the virtual reality, AR or augmented reality for remote telementoring. So again, my objective today is not to present as an expert in this part, but rather to share my project and to give an initial findings as well as our limitation, and so that whoever is interested of this kind of mixed method will have a better idea what are possible limitations that you'll encounter as well. So we do a registration as well to monitor our own outcome, and that's the reason in the process we'll have a better idea of the quality of care in terms of doing this education program. So basically this whole project had approval from SICKID's Research Ethic Board as well as the Philippine local institution. The device that we use is Vicious M400. It's a AR smart glasses, head-mounted. You can wear through where the actual surgeon who's operating over there will be able to see through the field as well as whatever annotation that you'll do over your iPad or your phone. And the image on the left side of the screen is basically a sample of what I can see through their eyes, and I'm on the upper corner. That's me with another surgeon looking through and giving some advice. So in terms of doing the mixed method, we also go there 1 week in person. Typically it's on December because otherwise it will be so hot. I just came back yesterday actually. It's 56 degrees in the Philippines right now. So the best month to go there actually, you need to kind of choose the timing. It's around November, December, and that's what we've been doing. And last year I recruited 2 additional faculties. One from Eastern Virginia Medical School and one from Queen's University who are expert in reconstructive urology. So overall, we kind of started in December 2022 in one institution and expanded with another institution last December. So again, we established a registry to monitor our outcome. We also assess the mentees' perception on before and after procedure confidence improvement, as well as their understanding of the procedure or at least the knowledge overall on the surgery. So just to share some documentation what we had, basically we go there. Dr. McCam is from Eastern Virginia Medical School. He was able to bring his own trainee with him. And Dr. Chris Dorian, who's in the middle, white shirt on the upper image, he was also able to bring one of the residents. Unfortunately, in Toronto, I was not able to bring a fellow resident at this point, but that will be my next step. And in fact, we're in the process of forming an alliance that we can do some exchanges where I can also sponsor one of the resident or local surgeon in the Philippines to come over and do some observership, or even better, if they're able to do some hands-on, if we're able to work on the CPSO. So we met with the leadership of their institution, and we got some recognition as well, and hoping that this will be a sustainable project that in long term we'll be able to do like more activities, and as well as do more exchanges. Towards the end of the 1 week, we also gave lectures that are in-person discussion and telecast that will let local other urologists able to join us. So as a quick result, we performed total of 20 procedures, so around 9 in 2022 as an initial trial and another 11 in 2023. This is the list of the procedure that we commonly can do. They are non-emergency, non-critical cases, because those are reconstructive cases are the ones that we can properly assess and schedule. So far, with a follow-up of 6 to 18 months, no intra-op or short-term complication are noted. 14 local surgeons were involved in this whole process, and they said they had a significant improvement. So this is just a quick analysis. It's a short number. I know we use a simple pair t-test. This might be biased as well because we're the one who's conducting the survey immediately after their procedure. Basically, there's an improvement of around 3 points from the baseline. It's a Likert scale of 1 to 10, how much they think they know, how much they're about able to comfortably do the procedure. So just a quick discussion. Again, the in-person part, probably everyone have more experience than myself. I'll just share the limitation that we encountered for the augmented reality. There are a few other studies or other centers have used the augmented reality. They noticed that the problem with their device is the short battery life. The device can get hot over a period of time, and the cost of itself. On our experience, again, I kind of shared this already in one of the Bethune Roundtable discussion, which is a global surgery forum we attended last year. It's the log time of around, now at least a second. Used to be it's a few seconds. Right now, after we troubleshoot with the local institution, increasing their capacity, the internet maybe become more like 5G already, and that's reason it's a bit lesser log time. However, we are all still concerned with the connectivity strength, and there's a possibility of disconnection. Then this become a safety issue. That's the reason with the augmented reality, we still be around the vicinity, just in case something happen, we can quickly run into the operating room to help them. And later on, if we're comfortable to make sure the technology really work well, then we'll start the full remote. And right now, the remote one that we've been working with the local surgeon is more of the diagnostic procedure or running through the diagnostics. Surgeon fatigue, both the mentor and mentee can get very fatigued wearing and looking through the iPad. And there's a 12 to 13-hour time difference between Philippines and Toronto. There's also a difficulty in recruiting patients because there's concern about privacy and confidentiality. It's also difficult to select appropriate cases for this one, as well as because there are safety concerns. And again, the Vicious Smart Glass have the voice control feature. However, you need to really speak out really correct intonation, or you can use the device by tapping on the side, but then it becomes a problem with the sterility. And that's our few of the limitations we encounter. So again, just to highlight what my previous panelists have highlighted, the global surgery is basically to improve global health, particularly in child health, if, in pediatric urology, for the vulnerable population in LMIC. And we would like to increase the knowledge, skills of our local surgeon, and particularly in long term, we are actually planning to build a satellite education program. And actually right now, we brought one of my junior colleague from the Philippines who is training with us. And we're hoping she would go back to the Philippines and become the local surgeon so that she could help. Well, if there's in case of emergency or disconnectivity, at least there's another surgeon there who knows how to troubleshoot or do the procedure and finish the whole thing. And again, this innovative approach may address inequality. This may sound more educationally sound than short courses, like one time and you never follow up on them or no continuity of care. We hope this would become a long-term mentorship with local surgeon with us. Again, it's same as any global surgery intention. This is to provide equity, diversity, inclusivity to our patient. We aim to really track down our outcome, not only for service, and we would like to ensure the quality of care in this whole project. So in conclusion, as I mentioned, this is a whole summary of our initial mixed approach of in-person and AR technology in telementoring, which showed feasibility, safety at this point because we're slow, and there are many limitations encountered and may hinder the long-distance telementoring. However, we think addressing this slowly will become feasible over time. And long-term commitment with follow-up of outcome is mandatory in global surgery. Thank you.
So thank you to all the speakers. So we have a few minutes for discussion. So maybe if I could ask the speakers to come up and we'll have a little bit of a panel discussion. And and we're open for questions. Perfect.
Fantastic. Thank you so much for wonderful talks. I also want to congratulate the arrangers of this whole symposium. They have the foresight and insight to plant global surgery in the middle of something else, right? So before I ask my question, I have a challenge to everyone, even the people who are not global surgeons here, who will become tomorrow's global surgeons. Let's have 10% of all the talks at your personal subspecialty meetings be represented by low and middle income countries or on global surgery. So it's not just us who talks about them, but them who talks to us. Thank you very much. I look forward to hearing the results of that next time. Jeff, why is your model not more widespread?
I'm not sure. It's such a simple idea. You know, the issue that I'm up against, I think, is government. You know, we've got a rich country, and they're pouring money into medical travel, in our instance, and misdirected funds, when there's simple solutions that are so much more efficient and so much more cost-effective. But how do you change policy? That's, you know, that's the question that I asked Dr. Miara on the break. And I'm up against some inertia. In fact, one of the projects that we're trying to duplicate this model now in Northern Ontario, our own, literally our own backyard, because there's the same discrepancy in Northern Ontario. There are a whole bunch of communities that are land and waterlocked that have to go to Kingston on the side of James Bay and Hudson Bay. They have to travel to Kingston to have the similar sorts of consultation, simple procedures. We've been trying to do a needs assessment now for a year and a half. Just to access data, the wheels are so slow to turn. The restrictions are very, and this is justified. There's some very, very stringent restrictions on accessing data for Indigenous population, and that's understandable. But we're still finding from a government perspective that things are very, very slow, and it's hard to make inroads. That's the only answer I have. I'm hoping for some guidance and enlightenment from other global surgeons, because I'm not really a global surgeon. I just want to help.
Well, we're about to hear from the expert.
No, not an expert. But following on that theme, in one of your last slides, did I get the impression that you want to talk to that government about possibly using some of the savings to reinvest?
Yes, correct.
So I wonder if they would be willing to commit to some of those savings to attract external funding. You know, could you get a social impact bond from someone, or could the University of Toronto help to say, hey, look, the local government's going to come up with $500,000 to do X. If we can get another $1 million from an external donor to do Y, some of it could be a capital investment, some of it could be for operations. But sometimes external donors are interested if a local government is willing to say, yeah, we'll put up some money for that.
Right. Yeah, that's an excellent suggestion.
And Rajiv, and actually all three of you sitting next to each other there. Paul Farmer would be so proud of you because it's an incarnation of accompaniment. So what you've been doing for so long is you're accompanying a local population, and he would be very proud of what you're doing. So thank you. Anna, you know me, and I'm going to go right to monetizing and advocacy and policy. Is there any way to monetize the excess deaths in that million death study, either human capital or VSL, just to show that, look, if it would be worth it to invest in this because you would reduce this?
Absolutely, and I think one of the challenges when we have so little understanding of what people die of and why they die is it's very difficult to even know where to begin to invest if you want to or if you don't want to as a government or at subnational kind of government levels. So certainly I think there is a way to look at that from an economic productivity perspective, from a social productivity perspective, but even just being able to show how many people die from emergency surgical conditions for the first time in the world's most populous country has been helpful in shifting the narrative at the district hospital level away from just the provision of primary care, maternal, neonatal and child health, which really dominated the district hospital kind of philosophy for a long time, to thinking about, emergency care, not just surgery, but emergency care in general. So yes, there's always a way to put an economic value on a life. We can argue whether that's right or wrong, but I think some of the bigger challenges have come from not even being able to measure who lives and who dies in most parts of the world.
So I think maybe just to close out this session, I'll ask each speaker to maybe give one sort of 10-second take-home message. And maybe, Michael, if we can start with you, and then we'll just go along the panel. Yeah, there we go.
So again, I think the criticism to global surgery is not able to follow up your own outcome, and I think this is particularly important of assessing the quality of care as well.
Thank you.
Probably my message, which was encapsulated towards the end of my talk, is that good research can be done everywhere, and your good research can also be done in low and middle income countries. So there is no reason to put up false barriers to the global collaboration and involvement of patients and communities from all around the world.
I'd say mine is probably from watching Dr. Fialkov over the last 5 years and seeing what's made him successful in this clinic. And I think I've come to see that number one is the relationships, and number two is patience. And sometimes things take a bit longer than we'd like, but honoring those relationships and the pace the community wants to take things at has been really an underlying key.
I would say, and I'll kind of paraphrase what the other experts here have said, and what I say to the residents, which is we're really blessed as surgeons to have an incredible set of skills that most people in the world do not have. That's a gift, and I think as human beings who feel or should feel that other people count as much as we do in our lives or no more valuable than anybody else's life, that we should share that gift. And there are so many ways of doing it. There's so many ways on the ground level to be involved, whether it's through programs or whether it's just thinking outside the box and figuring out ways that you can make an impact. I think it's important to remember that we have received this gift, we have these skills, and we should share it.
I will plus one that in this concept of the best of good citizenship, right? And I think I'm almost an obligation to try and lean into that. I think beyond that, the problem is seemingly overwhelming when we talk about these numbers, 5 billion people around the world. But I think the only way to start is you chip away at it, but it has to be done in a way that follows structure and principles, and there's a lot of work that has been done, by Anna and Dr. Mira and others to help frame, I think, what is probably the global surgery's moment in time. I think as as the world is ready to turn its attention to that, from as I walk through those last 50 years, the time is now, and I just think the way to chip away at it is through these principles that can be guided, in a way that allows us to hopefully scale. And I think we have to measure it, I think, and we have to publish it, and we have to learn from each other. I think that's one piece that haven't done particularly well so far, so that it's not about urology or plastic surgery, but it's like, what are we learning and what's the unifying theme that can sort of build this out in a more scalable way. So it's good stuff.
Great closing messages. I want to thank all of the speakers. Fantastic symposium.